as you all have observed, we've really made some enormous strides in our cardiothoracic program, the evolution of this over the last several years, and particularly proud of the great accomplishments of our thoracic surgery division, the outstanding national benchmarks, the public reporting, the great work that they do. We had an outstanding dinner last night with many of the folks who are involved, from patients to staff members to our faculty and trainees in our thoracic program, and really just delighted and pleased with the great work that Dr. Cook has done in organizing this division and leading it to the high level that it has achieved for us. Today, I'm going to turn over our introduction to him of our distinguished visiting professor, but only want to say there's a special personal relationship for me because Dr. Roush was one of the only women attendings at the University of Washington at the time when I was an intern there. And as I mentioned last night, I never really thought of her as a woman attending. She was just, and forgive me, and we probably are already announcing this, but I just thought she was a really kick-ass surgeon. So with that, I will have Dave do our formal introduction. Dr. Cook.
Well, thank you very much. It's my pleasure to introduce our next guest, Dr. Valerie Roush from Memorial Sloan Kettering Cancer Center. First off, I want to acknowledge the John M. Mott Jr. family for their generous gift to make this lectureship possible. Dr. Mott is one of the founding members of the UC Davis School of Medicine and a surgeon in the Sacramento community. So I would like to take a moment to thank the Mott family for making this possible. I have known Dr. Rusch for over 10 years as a member of the Advisory Council for Cardiothoracic Surgery. She is the Vice Chair of Clinical Research and the Minor Family Chair in Intrathoracic Cancers in the Department of Surgery at MSK. She epitomizes what an academician should be, achieving an impact in practice of surgery, commitment to quality outcomes for patients, and expert education for the next generation. In fact, she's educated many of the people in this room today. She's a giant in cardiothoracic surgery, specifically thoracic oncology, and has a leading role in defining the specialty, setting standards of care that epitomize patient care internationally. Dr. Rusch has served for decades as an educator, role model, mentor, and coach for countless students, trainees, and faculty surgeons, developing and shaping their careers. Her roles in the college have been numerous, with highlights including Chair of the Board of Governors Executive Committee, Chair of the Board of Regents, and Chair of the Clinical Congress Program Committee, as well as the Gibbons Lecturer. Since 1994, she's been a faculty member at MSK, defining the modern approach to thoracic surgical oncology. She served as Chief of Thoracic Service from 2000 to 2013, and she helped define the modern approach to thoracic oncology, as evident by over 390 peer-reviewed publications and leading over 20 national and international multi-institution trials. She also led the efforts to redefine the American Joint Committee on Cancer staging definitions for lung and esophageal cancer, which we all use today. So it's with my great pleasure to welcome Dr. Valerie Roush.
David, thank you very much. Let me just turn this one. It's really a pleasure and a privilege to be here to have a chance to spend some time with old friends and meet a few new ones. So I'm going to hypothesize what thoracic surgeons are going to be doing in 2030. I'm going to be using lung cancer as a paradigm, both because it's the most common disease that we deal with as general thoracic surgeons, but also because I think the evolution in this area over the past 20 to 30 years exemplifies what is happening in other areas of oncology, but also in surgery in general. So we'll take a little tour here where we've been, even in the span of my career, where we are now and where we're headed. And this has been really an extraordinary journey as I look back over the last 30 years and look to the future. So if you were to take a 30,000-foot view, so to speak, over time of what's happened in lung cancer knowledge and care, We start back literally a century ago in the development of safe techniques for resection. It's hard to believe that in the early part of the 20th century that techniques for lobectomy and pneumonectomy, for instance, were not well worked out and that the mortality was high. It was only in the 1940s that there were studies that started to link tobacco exposure to the development of lung cancer. And that was followed starting in the 50s by the development of clinical and surgical staging methods. So I'll tell you that when I was an intern and resident in general surgery in the late 70s and early 80s, that CT scan was just beginning to become available, and MRI didn't exist, and certainly PET scanning didn't exist. So that's amazing that all of that has happened within a relatively short span of time. And cervical mediastinoscopy really only came into general practice in the mid-70s. Staging systems for this disease were rudimentary, and as you probably know, we're in the 8th edition of the staging system, so it's evolved substantially compared to what was available when I was in residency. Multimodality therapy, so the use of effective chemotherapy and radiation only came into a general use really in the starting in the 1980s. A huge step forward was a large national study showing that CT scanning was effective for lung cancer screening, not only reduced overall mortality for this disease, but also mortality of some associated diseases like cardiovascular disease. And that has, as I'll talk about in a moment, completely changed the landscape of what we now see in our practices. More recently, there's been an evolution in thought about the use of sublobar resections, wedge resection, segmentectomy for some highly selected patients, and the advent of minimally invasive surgical techniques. So VATS lobectomy only came into practice starting in the mid-1990s, although it's finally, after a decade of trial and error, become a standard approach to the management of this disease. And robotic techniques are only beginning to make inroads more widely in practice today. And finally, starting really around 2004, is the advent of what I call the molecular era, which really is an understanding of the underlying molecular biology of this disease, which has completely transformed management, and I think is part of our future not just as oncologists in medical oncology, but also in thoracic surgery. So in the span of my career, if you were to take roughly a recent 30-year period, this is what's happened. When I was in residency training, if you had a patient with stage 1 or stage 2 disease and they were a candidate for surgical resection, that was it. They had surgery and then no further treatment. Stage 3A defined as patients who had more locally advanced disease with ipsilateral mediastinal lymph node metastases were treated with radiation. So we'd do a mediastinoscopy, we'd complete the staging. As I said, we didn't have PET scanning at the time, just CT in those days. And if you had lymph nodes identified on mediastinoscopy, you sent the patient off to the radiation oncologist. And only the patients who had either yet further advanced, locally advanced disease or metastatic disease, stage 3B or 4, were treated with systemic therapy, with chemotherapy, such as it was in those days. Platinum-based chemotherapy only became available really in the mid to late 80s. By 2012, things get a lot more complicated. Surgery still being the mainstay for patients who have the physiological reserve and have stage 1 disease. But you see that chemotherapy is coming in as either adjuvant or preoperative induction chemotherapy for patients who have stage 1B or 2. And then the algorithms for management of stage 3 disease get even further complicated with the use of chemotherapy and or radiation and or surgery in various combinations depending on the extent of disease, and the physiological reserve of the patient. So with all of this, over a 30-year period, we're able to achieve statistically significant but clinically very modest improvements in patient outcomes. And until very recently, that we were really at a therapeutic plateau. I would say up until the last 10 years, we had gone through a period of time of about 20 to 25 years where not much had changed except to look at various permutations of combining surgery, chemotherapy, and radiation. So what's happened recently? A great deal. Well, the first is the advent of technical and technological advances in the management of this disease, either very early stage disease or locally advanced disease. A lot of controversy about the extent of resection. In this sense, the management of lung cancer, the evolution in that management, mirrors very much what happened in breast cancer in an earlier time frame. So believe it or not, when I was a medical student up at Columbia Presbyterian, you would make rounds in the morning and there'd be a long ward of women who had had Halsted radicals with skin grafts on their chest wall. And when I went to the University of Washington to do my general surgery residency, it was like, wow, you can do a modified radical mastectomy. And obviously today, most of those patients are, first of all, discovered with earlier stage disease, and secondly, managed with lumpectomy and sentinel lymph node biopsy. So we've had a parallel process going on in lung cancer, especially since the national trial that I referred to and that demonstrated that CT screening is useful. And this has resulted in our seeing many, many patients who have very small primary tumors. So CT scanning in this disease is like the mammography of the lung. And this is a controversy that is still unsettled, and the controversies sort of revolve around the extent of a lung resection that's necessary, but also to a certain extent around the extent of lymph node dissection that's appropriate. And the third thing that's happened is the advent of personalized or so-called precision medicine on the management, particularly of locally advanced non-small cell lung cancer. Now, new technologies and new techniques have had a major impact on what we do every day in the operating room. And last night when I gave a talk about the evolution to robotic surgery, I pointed out that, again, in the span of my career, these are the technologies that I've had to incorporate into my practice. They start with flexible bronchoscopy, laser bronchoscopy, the addition of video technology to mediastinoscopy, VATS, which the video thoracoscopy came into existence around 1991. Then the development of more complex VATS-based techniques with VATS lobectomy. More recently, robotic VATS, and I've highlighted those two because I think they are the two procedures that have really forced us as thoracic surgeons to learn entirely new skill sets that are a quantum leap. Going from mediastinoscopy to video mediastinoscopy is not difficult, but doing complex techniques minimally invasively has been a quantum leap forward. And then additional technologies like endobronchial ultrasound, or EBUS, and navigational bronchoscopy. In some areas around the world, and I was just in China about 2 or 3 months ago at a meeting, and the whole rage over there the meeting was at the Shanghai Chest Hospital, where they have, so I was just saying to David, they have 50 thoracic surgeons on staff. The volume is something that is hard for us to understand. So they literally do something like 40 lung resections a day over there. And their big rage is not robotic, but it's uniportal VATS. So it's doing minimally invasive procedures through smaller and smaller incisions. Well, their patients are not our patients. The body habitus is different. They don't have as many patients who are tall and obese and whatnot. And obviously in this country, different situation, access to robotic technology, I think increasingly more and more programs are incorporating robotic procedures into their armamentarium, including where I work, where we do a very high volume of robotic procedures. So what does this mean? We looked at, in this publication, at our patients who had clinical stage 1 lung cancer. This is data from our thoracic surgical group at MSK. It represents an early experience. We have a much higher robotic volume now than we did during the time this study was performed. But so over 2,000 clinical stage 1 lung cancers, and this study looked at 470 patients in a propensity matched analysis, looking at results from robotic lobectomy, VATS lobectomy, and open lobectomy. And in a sense, this was selected by surgeon skill set, because there were surgeons at this time who were still only doing open procedures, some of us who were doing VATS lobectomy, and some of us who were doing robotic lobectomies. And unquestionably, as we made that transition from primarily open procedures to minimally invasive procedures, we shortened the hospital stay by a day or two, and now it's more like down to 2 or 3 days of hospital stay. Not surprisingly, there was no difference in disease-free and overall survival, because anatomically you can do the same operation for early stage disease, whether it's minimally invasive or open. And you do end up doing more complete staging, especially when you do robotic procedures. It's hard to do those without doing very complete lymph node dissections. Whether that's important for patients who have stage 1 disease is debatable, but certainly for more locally advanced tumors, it is important. So certainly in my own practice, as I move towards incorporating robotic technology, this has changed what I do and how I do it. So most mediastinal tumors we now do robotically. Robotic technology has become very useful for patients who are reoperations, even if it's a second or third reoperation, because it's very, very easy to lyse adhesions robotically, much easier than it is by VATS. Very obese patients, this is a great technique because it's a completely closed technique where you use insufflation. And as any of you who do laparoscopic work know, once you insufflate, everything becomes easier to see and easier to manage. And for us, it means getting the diaphragm down out of the way, increasing the size of the pleural space, and having more room to maneuver and better exposure. There are some particular situations where this is useful. Patients who've had previous coronary artery bypass grafting, particularly if they've had a left internal mammary graft, which can be a very tricky situation, particularly if you're doing a left upper lobectomy. Now, rather than doing those patients open, I can do it closed. And increasingly, I'm doing selected patients who've had preoperative treatment, either preoperative chemotherapy or immunotherapy, or sometimes even radiation, and doing those in a minimally invasive technique. And in my own practice, I've now, as I've looked back over the last 2 years, been able to move towards doing 90% of my lung resections this way, as opposed to doing thoracotomy. There are all sorts of things on the horizon that I personally would not even have thought about a few years ago. So here's an example of how robotic technology is going to be linked very shortly to our doing bronchoscopy, and particularly navigational bronchoscopy. So as you can see in the photo on the right, that's one of our interventional pulmonologists there. You can have a bronchoscope mounted on a stable robotic platform here, just like you do if you're doing robotic surgery for robotic lobectomy. So you're actually not holding the bronchoscope. It's manipulated off of a joystick over here. And you'll be able to see the standard visual image looking down the bronchoscope, just like you do with standard bronchoscopy, but simultaneously be able to follow the location of the tip of the scope on CT scan, so that you can travel way out into the periphery of the lung. And so just stop to think for a moment that in a single procedure, Instead of sequentially sending the patient to the interventional radiologist to do a needle biopsy of a lung lesion, we could, on one trip to the operating room, get the biopsy of the primary tumor, do the staging by endobronchial ultrasound, and if we're not satisfied with the results of that, we could also do a mediastinoscopy. So with one-stop shopping, so to speak, you can get the diagnosis, do the staging, and get the patient appropriately selected for treatment. It's taking what is now a sort of 2 to 3 week endeavor and reducing that to one trip to the operating room. So these are the kinds of technologies that continue at a very, very rapid rate to transform how we function as thoracic surgeons. And there are going to be a host of things that I'm sure in the next few years that I can't even conceive of that are going to be new techniques and new technologies that we incorporate into our practices that are rapidly altering the patterns of patient care. Having said that, I think it's incredibly important to not just say, oh, got a new toy out there. Yes, it costs $1.5 million, but let's start using it tomorrow. It's really incumbent upon us to look at new technologies and new techniques in an objective manner, to study it in terms of morbidity and mortality, not just 30-day, but 90-day outcomes, which I think in surgery in general, and certainly in thoracic surgery, 90-day outcomes are a much more precise measure of our outcomes. Yes, of course, to look at the impact on hospital length of stay, but to also look not just at hospital charges, but hospital costs, the impact on the patient experience, so patient-reported outcomes and patient quality of life. And we need well-designed prospective studies, yes, from high-volume institutions, but also if you have lower-volume, high-quality institutions from multi-center studies, really taking a very stringent, objective look at the value or lack thereof of new techniques and new technologies in our practice. So as I mentioned, the other area that's one of great controversy and one of evolving management in early stage disease is the extent of lung resection for patients who have stage 1, particularly stage 1A tumors. And for now at least a couple of decades, this prospective randomized clinical trial, which was done by the Lung Cancer Study Group, LCSG 821, that was one of the NCI-funded cooperative groups, randomized patients between lobectomy versus limited resection if they had a stage 1 tumor. And I'll tell you, because I was one of the surgeons involved in this trial, that what you actually did was the standard preoperative assessment, but then in the operating room you did a lymph node dissection. You made sure that technically you could do either a lobectomy or a sublobar resection. And then you went to the telephone and you called the statistical center and you randomized the patient to either lobectomy or sublobar resection. And this study showed no statistical difference in overall survival, but a significant difference in time to recurrence, particularly local recurrence. So the mantra based on this trial for the 30 years was that the standard of care for patients who had T1N0 non-small cell lung cancer was a lobectomy. If you went to take your board exams, that was the correct answer. So the advent of CT screening has completely changed this, as I mentioned, the mammography of the lung. So that now in our practices, I can't tell you how much time I spend talking to patients who have 1 centimeter ground glass opacities. It's like going to the breast clinic where you're talking about management of tiny tumors and you're having lengthy conversations about the extent of resection and what you should do with the axilla and the multimodality therapy and adjuvant radiation, this and that. It's gotten just as complicated as breast cancer management. So 2 trials are going to have a very significant impact on the standard of care for this situation. One is a trial done by the Japanese Clinical Oncology Group, did a randomized trial taking patients who had what they loosely call very early lung cancers, and that's loosely defined as tumors that are 2 centimeters or less in size. They specifically excluded patients who had just a pure ground glass opacity, because that usually indicates a patient who does not have an invasive component to the cancer. And they've randomized them to either lobectomy or segmentectomy. So it's taking the old lung cancer study group trial and redoing it, but for patients who have earlier tumors, because that's now what we see these days. And the Japanese really led the way. They're way ahead of Europe and North America. They were the first ones to do CT screening. They were the first ones to define what a ground glass opacity means, to begin to look at subsets of lung adenocarcinoma and the different outcomes according to histology, and to define the fact that perhaps you didn't need to do as extensive a lung resection in these patients as we had thought for a long time. So this large trial completed accrual now 2.5 years ago, which means that in about another 2.5 years we will have sufficient follow-up in terms of overall survival to have publishable results. And as you can see, they did actually meet their accrual target, which was over 1,000 patients, so it's going to be a very, very robust and well-done trial. The second trial started after the Japanese trial and conducted by one of the lung cancer NCI-funded cooperative groups, completed accrual about a year ago, and it was very similar in design, also focusing on these early lung cancers, 2 centimeters or less in size, excluding patients who had, in quotes, pure ground glass opacities on CT scan, and randomizing them to either lobectomy or sublobar resection. You'll notice a subtle difference here. The Japanese did either lobectomy or segmentectomy. The North American trial, with some controversy, includes wedge resection, so not an anatomic resection, and sometimes there's an issue about margins of resection if you do a wedge. This trial also very robust in terms of sample size, 1,200 plus patients, and it'll be a very important trial, but many years before we get enough survival data to really have results that can be analyzed and published. So why is this particularly important? Well, I mentioned the fact that we see patients who have earlier and earlier stage disease, but we're also seeing more multifocal tumors. So there's been an evolution in histology from predominantly squamous cell, which is what we saw when I was a resident, to 85% of our patients having adenocarcinoma. And for reasons that we don't fully understand, I actually think it's a biological difference, but that's debatable. We're seeing more and more patients like the one shown here. So patients who have multifocal tumors. This is an adenocarcinoma in the left upper lobe. This is also an adenocarcinoma over here. One is not metastatic from the other. They're independent primaries based on histology and molecular findings. And we see this not only synchronously, but metachronously. So we have a lung cancer survivorship program at MSK, and we provide lifelong follow-up for all of our lung cancer patients who are 2 or more years out from either the resection or the primary definitive treatment. Why? Because 3 to 6% of these patients per year develop a second primary lung cancer. And if we provide lifelong follow-up and early detection of that next primary, we know that in over 90% of those cases, we can provide curative treatment. Curative treatment might be another operation, it might be stereotactic radiotherapy, it might be radiofrequency ablation, but we can provide curative therapy. And we're also seeing more and more so-called subsolid tumors, which are tumors like this that have a central component, which is solid, and then a little stuff around the periphery here that doesn't look solid. And that usually means that there's invasive cancer here and non-invasive cancer, or so-called lipidic adenocarcinoma, in the periphery. Or here's also a subsolid lesion. You can see areas of lung parenchyma that are aerated with other areas that contain adenocarcinoma. So in effect, as we talk about precision medicine or personalized medicine in the management of patients who have early stage cancers, we're talking about personalized surgical approaches. And again, I would just draw the analogy to breast cancer. It's very, very similar. Each patient who comes in who has a breast cancer is not managed the same way as the next person. The same is now true for lung cancer management. So the rationale for thinking about these lesser operations, first of all, they are slightly lower risk procedures in terms of morbidity and mortality. We have to think about not only what is a good cancer operation today, but think about what we do long term for these patients who are, as I mentioned, a high-risk population for second, third, and fourth primary tumors. So you have to balance initial cancer treatment with allowing enough lung reserve to do something else in the future, and preserve the treatment options for those metachronous non-small cell lung cancers that develop in these patients. Then the next area that's still unsettled is the personalized approach to staging lymphadenectomy. We know that each lobe of the lung has its own anatomic site of lymphatic drainage. There is about a 5 to 8% risk of what we call skip metastases, which means mediastinal lymph node metastases in the absence of hilar or peribronchial nodal metastases. We know that the risk of mediastinal lymph node disease, so-called N2 disease, is roughly related to tumor size and histological subtype, but not entirely. And there's some who say that a lobe-specific lymphadenectomy, so just taking out those lymph nodes that you know are the high-risk lymph nodes for that particular anatomic location, can simplify and shorten the operation and potentially facilitate surgery for metachronous primary tumors. But this is certainly an area where we need more prospective data, and it's an unsettled controversy in the land of thoracic surgery. Just think, again, hearkening back to the breast cancer management, about how long it took to go from axillary lymph node dissection to sentinel lymph node biopsy as a routine management. And we're now going through a very similar algorithm here in terms of lung cancer management. So one thing that has really changed our understanding of what might be appropriate for patients is the development of a new histological classification for lung adenocarcinoma, which, as I said, is our most common tumor type. And this is now the new World Health Organization histological classification, and you'll be grateful that I'm not going to walk all the way through it. But suffice it to say that it breaks down into 3 categories, which is low risk, intermediate risk, and high risk, with the low risk defined as patients who have adenocarcinoma in situ, or those lipidic adenocarcinomas that I mentioned earlier, the intermediate risk patients who have asthma or papillary histology, and the high risk being solid or micropapillary. Why does this matter to clinical management? Well, it turns out that the patients who have a significant, greater than 5% micropapillary component to their tumors have a higher risk of local recurrence. So this is data, again, data from our own institution, showing that if you do a sublobar resection, the patients who have that component of micropapillary histology have a higher risk of local recurrence as opposed to patients who have a lobectomy, both in a training set and a validation set. Moreover, if you look at a different histological subtype, those patients who have a component of solid tumor histology versus those that do not, the patients who have solid histological subtype have a high risk of metastatic disease. So if I send a patient to the interventional radiologist to get a needle biopsy for diagnosis, and our pathologists are able to look at that, if it's a good core biopsy, they can often define the histological subtype. And if it comes back with a micropapillary component, even though the CT scan might look like a pretty innocent subsolid lesion, as I showed you, I know that that patient probably deserves a lobectomy. And if it comes back with a solid component, you might also consider doing a lobe, depending on tumor size. But really, that's a patient where you should be thinking about adjuvant therapy postoperatively, because they have a very, very high risk of systemic progression of disease. So this has really refined how we select patients for surgery and manage them in our clinical practice every day. So the patients who have not stage 1 tumors, but stage 2 or stage 3A are now being managed very, very differently from the way they were managed 10 years ago. Why is that? Well, just as there's been a paradigm shift with a personalized approach to surgical management, there has been a huge paradigm shift in precision medicine with molecularly based therapies for patients who have more locally advanced disease. So the first thing that's changed this is the understanding of the different biological subsets of lung cancer. We now know that patients who are never smokers or former light smokers, I call it the collegiate smoker, the person who smoked 5 cigarettes a day for 2 years when they were in college, versus the 2 packs per day for 40 years kind of patients. Those patients are likely to have biologically very different lung cancers with different prognoses and different treatment options. So molecular profiling in some dimension has now become standard of care. You could go to any community hospital in this country and there is a mandatory standard of care within the medical oncology world that at least some level of molecular profiling be done on every patient with newly diagnosed lung cancer. Now, we happen to do that because of the environment in which I work at a very sophisticated level. So we have a molecular platform which is called MSK Impact, which can look in a multiplexed manner at over 400 genetic mutations and amplifications that are known to be important in a variety of cancers. And so I can send a resected tumor, which we do on every lung cancer resection, off for impact testing, and a month later get a full analysis for these 400 plus mutations, which in turn can alter the treatment options for that patient if they're being considered for adjuvant therapy. So routine molecular profiling, and this is going to become, it's going to get cheaper and faster and more widely available to community hospitals as well as academic centers. The development of new drugs, and the first in line in this area were so-called targeted therapies. These are drugs that target very specific mutations in selected lung cancers. And lastly, the newest development here are the development of drugs called immune checkpoint inhibitors, which I'll talk about in a moment. So basically a form of immunotherapy which has caused incredible excitement in the oncology world because it's really transformed treatment for many patients. So 2003, 2004, as happens so often in science, the time is sort of ripe for a new discovery, and there were three institutions that really almost simultaneously made the same discovery. So the Dana-Farber in Boston, MGH, and MSK. And they discovered that there were a group of patients who had selected mutations in the epidermal growth factor receptor who were highly susceptible to treatment with tyrosine kinase inhibitors. So it was the first of the so-called targeted therapies. How did this come about? Well, pharma, in their infinite wisdom, had a new drug, and they decided to do global trials, which is increasingly the pattern and with big pharma. And they took an unselected group of patients internationally to treat with this new drug, which was called gefitinib, or Iressa. These are patients who had locally advanced or metastatic disease, and it did absolutely nothing for most patients. But then it became apparent that there were a few patients in these trials who had an incredible response. It was like turning the electric light bulb on and off. And so here's an example. This was something that we had never seen before in patients with metastatic disease. So a patient who is diagnosed here in the beginning of the month of July with, this is the primary tumor over here in the lung, is found to have an EGFR mutation, gets started on treatment, and within 3 weeks, you can see an incredible response, which is sustained as of several months later. This was sort of mind-shattering because this is a patient who probably would have had 6 months to live with standard chemotherapy. And so this is a fantastic story of bedside to bench research and back again. So astute medical oncologists recognized that there were some outliers, and then they studied the outliers, and this is how the discovery was made. And from there started the entire field of precision medicine for metastatic disease and now for more locally advanced disease. Very quickly following that discovery was the discovery, because we suddenly started doing mutational analysis on a lot of lung cancers, of a series of other mutations. Some of them were not common. They maybe occurred in 5% or less of lung cancer patients. The ALK translocation was the second one of these so-called targetable mutations that was discovered. But these drugs, the targeted therapies, were an incredible addition to the armamentarium of systemic therapy for patients. And so if you look historically at what happened for patients who had metastatic disease, and that's still about 50% of lung cancer patients, 50% of them walk through the front door with metastatic disease. In the era before platinum-based chemotherapy, the median survival would have been something like 4 months. And as you migrate through the era of various development of various cytotoxic chemotherapies, you can see that median survival time stretching out to 1 and then to 2 years. And when you get to the targeted therapies, 2 years plus. So this is roughly what's happened since 1999. You started out, in those days, we knew only about one subset of patients who had KRAS mutations. Anyone in this room who deals with colorectal cancer or pancreas cancer, you think about KRAS mutations. It's about 25% or so of patients who have lung cancers as well. By 2004, we knew about EGFR in addition to KRAS, but 60% of lung cancers still were sort of a black box with unknown biological abnormalities. And by 2014 or thereabouts, this is the pie chart. So KRAS, EGFR, and then a whole host of these less common but highly treatable, targetable mutations. And we're now down to about a third of non-small cell lung cancers where we don't really know what the key molecular abnormality is. But this is why treatment of these patients has been transformed, and they are living longer and longer with their cancer. Patients who have targetable mutations then often go on after 1 or 2 or 3 years to develop resistant mutations, and so we're now into the second, third, and fourth generation of drugs that target the resistant mutations. So what happens increasingly is you get your tumor studied before you start treatment. You develop resistance, you get rebiopsied, studied again, you go to the next drug for a period of time. You develop resistance, you get rebiopsied and get another molecular profiling on your tumor and go to the third or fourth generation drug. So it's really greatly extended the life expectancy for these patients, and they are extremely well tolerated drugs so that people are taking a pill every day and walking around with very few side effects. It's a dramatic advance. So very early on in this story at MSK, we decided to test this for patients who had resectable disease. So I was taking this history that I showed you with targetable mutations and moving into the management of patients who had resectable disease. And we did something that we called the POP trial, Proof of Principle trial, in which we identified patients who had known or were suspected to have EGFR mutations. And we asked them to have treatment with gefitinib for 3 weeks. We actually delayed their operation for 3 weeks. We biopsied them before the drug, and then we had the surgical biopsies, so they had a molecular profiling of their tumor pre-treatment and post-treatment. They had pre-treatment CT and PET scans and post-treatment CT and PET scans. And we then operated on them after they'd had this induction therapy. And we showed exactly what you would expect, which is if you had if you had a targetable mutation for EGFR, and there are 2 of them that make you highly susceptible to this class of drugs, the L858R mutation, the exon 19 deletion. But bottom line on this waterfall plot, if you had either one of those, you had an extremely high likelihood of having a significant response to just 3 weeks of treatment with those drugs. So this has led to some additional trials that I'm going to show you in a moment that now incorporate molecularly based treatment as a routine into the management of patients who have early stage disease. And of course, as I mentioned, what's really facilitated all of this is the revolution in molecular profiling. So within the space of just a few years, we've gone from having this platform, which could only give us information about 8 genes and point mutations only, to having this platform, the MSK Impact, which, as I mentioned, tests for over 400 cancer-related mutations, as well as looking for deletions, insertions, and amplifications with a comparable time and cost for analysis. And obviously, it's only going to get faster and easier as time goes by. And this is what's happened clinically. So it's gone from the fantasy of a New Yorker cartoon on your left, where you see the patient handing in their sequence to the pharmacist, to the reality of the prescription on your right, which is Mark Chris, who's the former chief of thoracic medical oncology at MSK, writing for an oral chemotherapy drug based on the presence of a BRAF mutation in a patient's lung cancer. And as I said, this is now an NCI-funded trial, very large multi-center trial that is selecting the adjuvant therapy for patients who've had resection of early-stage lung cancer, adenocarcinoma, based on their molecular profiling, so that patients who have an EGFR mutation get EGFR tyrosine kinase inhibitors. Those that have ALK mutations get appropriate drug for that, crizotinib or other drugs. And the patients who have do not have a targetable mutation based on molecular profiling now get immunotherapy with the immune checkpoint inhibitors. So this treatment, having started out in metastatic disease, is being moved into earlier and earlier stage lung cancers. So the latest new kid on the block, so to speak, in this area that is directly affecting what we do as thoracic surgeons in this disease are the immune checkpoint inhibitors. And the 6 drugs that are currently in clinical trial target either one of 2 pathways. They're either anti-CTLA-4, so those drugs reduce Treg-mediated immunosuppression, or they target the PD-1 pathway and restore activity of quiescent anti-tumor T cells. So they basically do something to the immune pathway to allow your body to recognize that a foreign process is going on and to allow your T cells to attack the tumor. There's some information demonstrating that if you attack both of these pathways, that they may have a synergistic effect, but perhaps at the price of greater toxicity, and also that they may be synergistic with cytotoxic chemotherapy. So as I mentioned, there's 6 drugs either now approved for use or in various stages of clinical trials. Please don't memorize them, but here they are. 2 CTLA-4 drugs. Anyone who deals with melanoma in this room knows all about ipilimumab. They also know about Pembro and nivolumab. So they're either anti-PD-1 or anti-PD-L1 or anti-CTLA-4 drugs. And there were 2 key trials for patients who had advanced lung cancer that led to FDA approval for the anti-PD-1 drugs, specifically in this case nivolumab, for both squamous and non-squamous tumors, both published in the New England Journal of Medicine. So this was the trial that led to approval for the use of nivolumab as second-line chemotherapy, so patients who'd failed or progressed after cytotoxic chemotherapy, and a similar trial for patients with advanced non-squamous disease. Having established the usefulness for patients who failed cytotoxic chemotherapy, then the next generation of trials looked at these drugs as the first drug for patients who had metastatic disease. And most of these drugs have used a staining for PD-L1 as the selection point for using these drugs, although we know that's not necessarily the best biomarker. But this trial, which compared pembrolizumab to chemotherapy in PD-L1 positive non-small cell, established the use and led to the FDA approval of the checkpoint inhibitors for treatment as the primary treatment for patients who had metastatic disease. And for anyone in this room who's dealt with patients who receive these drugs, they're not without toxicity, but it's a lot different than taking platinum-based chemotherapy. Patients are not dragging their tails into your clinic after they've had preoperative treatment looking fatigued and nauseated and just like they've been put through the ringer. So in general, the toxicity is much lower with these drugs than it is with platinum-based therapy. Okay, so what does this have to do with thoracic surgery? Well, it is transforming how we manage patients with resectable, locally advanced disease. So this trial, which is actually in press in the New England Journal, it was presented at the European Society of Medical Oncology in 2016, at ASCO in 2017, and is now in press, was a small two-institution trial that we did in conjunction with Johns Hopkins, taking patients who had potentially resectable but locally advanced non-small cell. Again, doing biopsies, molecular profiling, various blood draws for biomarkers, pretreatment, giving them 2 cycles of preoperative nivolumab, so an anti-PD-1 inhibitor, operating, and then doing a whole set of biomarkers postoperatively on the resection specimen, and then standard of care following that. And the bottom line to this single-arm phase 2 trial, first of all, very low toxicity, no delays to surgery, and an astounding 43% major pathologic response, which is defined as 10% or less of residual active tumor. If you gave someone platinum-based chemotherapy, you would expect to see 5% major pathologic response rate. So if you were to go to clinicaltrials.gov and look at the number of checkpoint inhibitor trials being done for lung cancer in general, you would find about 250 active trials. That's how much enthusiasm there is in the medical oncology community. About 9 or 10 of those are being done in patients who have resectable lung cancer. This is the largest one that's ongoing and has accrued about almost 50% of the planned target accrual of 180 patients. And it happens to use atezolizumab, which is an anti-PD-L1 drug, and it's the same format as the nivolumab trial that I showed you. So these patients get standard preoperative staging. We delay their operation for 2 cycles of checkpoint inhibitor therapy. There are a lot of, again, biomarkers that are being drawn and looked at in the pre-treatment setting because we don't fully understand how to select these patients for treatment. They then go to surgery. They get restaged after the induction treatment. Their tumor specimen and lymph nodes and various serum biomarkers are looked at postoperatively, and they then are candidates for adjuvant therapy if they have had a major pathologic response. So this is an incredible evolution in treatment over the last 20 to 30 years. The approaches to the management of patients who have early stage disease are now based on tumor size, but also tumor histology. And as I showed you, within the next 5 years, we'll have major randomized clinical trials that are going to further inform the selection of surgical approaches to this disease. The advent of molecular profiling, and I think lung cancer has been sort of become a poster child in the world of oncology for the use of molecular profiling upon which you select treatment. So the use of molecular profiling, the advent of targeted therapies, and now the advent of the checkpoint inhibitor drugs is radically altering the use of both adjuvant and induction therapies to this disease. And these large ongoing trials testing the use of these drugs in the preoperative setting is going to change how we function. I would also say it's changing a little bit how we manage patients who have metastatic disease. So we now occasionally see patients who present with stage 4 disease. They get a checkpoint inhibitor. They're still alive, doing fine a couple of years later. Their metastasis has disappeared, and they now have residual something in the primary site. And some of those patients are now being sent to us for resection, something I couldn't imagine would happen 20 years ago. And so it becomes very important that we as surgeons are involved, have an understanding of the biology of the disease. We're not just doing the operation, we're treating the disease as well as doing the operation. It's critical that we as surgeons be involved in the design and conduct of trials like this that are changing the standard of care for our patients. So I think you could apply what's happened in lung cancer as a paradigm, certainly to many, many areas of surgical oncology, but also to surgery in general. Because of new technologies, what are we going to be doing in 2013? Functioning very differently from the way we function today. I think in many ways, hopefully better, faster, more efficiently, and hopefully, ultimately, more cheaply. We're going to be doing procedures for somewhat different indications. In some cases, lesser operations for tumors that we can define as being more indolent based on imaging and based on biology of the disease. And in some cases, we may be doing salvage surgery for patients who are surviving longer and longer after their systemic therapy and have residual primary tumors that need to be resected. And as surgeons, we're going to be more and more responsible for integrating surgical care into this increasingly complex process that is based on the biology of the disease. So thank you again for the opportunity to visit and to speak here this morning. It's really been a pleasure and a privilege.
Well, thank you, Dr. Roush. Really a great example of the importance of staying up to date with such rapidly evolving technologies, both from a surgical point of view, but about a biologic point of view. I certainly recall that it wasn't that long ago where the diagnosis of lung cancer in our parent or a grandparent was really just a fatal disease and there wasn't much to do about it. We have time for one question, and since I see Dr. Gandera in the room, I just thought I'd give you the opportunity to see if there's a question or comment you'd like to make.
Thanks. Well, first, thanks, Valerie, for a wonderful presentation. Valerie and I go back many years.
We're not counting.
Yeah. So one thing that I'd like your opinion on, and I realize there's no easy answer for this, is almost every week in our thoracic tumor board, we have a case where a patient had stage 1 lung cancer resected 18 months before, and now they have a solitary new lesion in their lung, which wasn't there before. And so the question, of course, is this metastasis? Is it a second primary, or is it the disease that you described, which is multifocal carcinoma that now has become apparent, which has a lot of implications in terms of is it going to be a continuing process? Do you have any thoughts on that differential?
Very tough situation, which, as you said, is sort of a daily event. A weekly event at the tumor board, and it's something we see all the time in our practices and struggle with. I think we base those decisions in MSK on histological subtyping, first of all, on the supposition, and it is a supposition, that if you have a different composition of histological subtypes for the adenocarcinomas, that it is most likely to be a separate primary tumor. And then we have some data to back that up, as you know. And secondly, on molecular profiling. So as I mentioned, about 3 years ago, once we got impact testing up and running at MSK for patients who had advanced disease, we took that process and implemented it as a routine for all of our patients who are going through resection. Now, interestingly, that's not, as you know, standard of care in most institutions, but it is reimbursed by insurance. And so we do that on all of our patients with resectable tumors, partly for this reason, but partly because it expedites the planning of adjuvant therapy. So we'll do molecular profiling on that new tumor, whatever it is, and try to make that decision based on histological subtyping and molecular profile. That's about the best we can do. It's still more an art than a science, I think.
Yeah, our case last week had the same EGFR mutation in the second nodule as the original primary. So in that particular case, we thought it was multifocal, we thought surgery was the best approach.
Well, sometimes it is the best approach if it's a solitary site, no matter what you're dealing with. And you're left with sort of making a practical clinical decision.
I also think particularly as surgery has become less morbid than it was decades ago, it gives people different options. So as we all think about our parents, our colleagues, our friends that we have to, we're often asked, despite what your specialty is, what's your recommendation? The message is it's a much more complex thing and you need to get more information to make it. So thank you again, and I really appreciate having you here with us today.
Absolutely. Yeah. Thank you.